Okay, let's talk about this. The patient with low mood. Okay, as usual, start with case summary. Mhm. Mrs. L.M. She's 32-year-old married housewife with two children aged 4 and 6 years, presented to her general practitioner stating that she was persistently unhappy and had been crying repeatedly over the past few weeks. She had no previous psychiatric history or significant medical history, and her only regular medication was oral contraception. She had moved to the area 3 years earlier when her husband was promoted, and at first appeared to have integrated well into the neighborhood by involving herself in the organization of a toddlers group. Unfortunately, the group had dissolved a few months ago when her co-organizer and only close confidant had moved away, deprived of her most important social outlet. Mrs. L.M. found herself increasingly dominated by her young children. Although usually an outgoing person, she noticed that her motivation to keep in touch with other mothers from the group had started to dwindle. At the same time, she started feeling persistently weary, even though her work schedule had not increased, and often awakened 2 to 3 hours earlier in the morning. Although her appetite had not increased, she had turned to food for comfort and had gained over 14 pounds in weight. Mrs. L.M. also candidly admitted that she was drinking more alcohol than usual. She described feeling incompetent because she was always miserable and had become too tired to look after the children. She felt guilty for burdening her husband and started crying when talking about her loss of interest in sex and her feelings of unattractiveness. Mrs. L.M. maintained that no aspect of her life gave her pleasure, and when asked specifically by her doctor, admitted that she had started to wonder whether her children and husband would be better off without her. So, for a discussion for the case study, we will talk about this later in this chapter. Okay. Definitions and clinical features. Core symptoms. Whereas feelings describe a short-lived emotional experience, mood refers to a patient's sustained, subjectively experienced emotional state over a period of time. Patients may describe a depressed mood in a number of ways, such as feeling sad, dejected, despondent, down in the dumps, miserable, low in spirits, or heavy-hearted. Okay, heavy-hearted. Okay. They are unable to just lift themselves out of this mood, and its severity is often out of proportion to the stressors in their surrounding social environment. Hints and tips. At least 2 weeks of daily low mood, loss of interest or pleasure, and fatigability are the 3 core symptoms of depression: low mood, loss of interest, and fatigability. The term affect has 2 uses in psychiatry. It can be used synonymously with mood or emotion, as in the affective mood disorders. However, it's most often used to describe the transient natural fluctuations of emotional state that occur from moment to moment. For example, you might notice a patient is tearful when discussing the death of their mother, but smiles when discussing their holiday plans. The range and appropriateness of a patient's affect is documented as part of the mental state exam. People with depression may have a reduced range of affect, with monotonous voice and minimal facial expression. The International Statistical Classification of Diseases and Related Health Problems, the 10th edition, ICD-10 classification system, specifies three core symptoms of depression. Depressed mood, which varies little from day to day and is unresponsive to circumstances, although diurnal variation may be present, with mood worse in the morning. Markedly reduced interest in almost all activities associated with the loss of ability to derive pleasure from activities that were formerly enjoyed, partial or complete anhedonia, and lack of energy or increased fatigability on minimal exertion leading to diminished activity, anergia. A range of other symptoms are also associated with a depressive episode. They can be considered under the subheadings biological, cognitive, and psychic symptoms. Biological, cognitive, and psychic. Hints and tips. Remember, the distinction between the terms mood and affect, they are not the same. One way to remember the difference is that mood is like the climate and affect like the weather. Another hint. Know the biological symptoms of depression. They are often asked for in exams. The key ones relate to sleep and appetite. Let's talk about biological or somatic symptoms. In the past, psychiatrists distinguished between endogenous or reactive depression. Endogenous depression, also called somatic, melancholic, vital, or biological depression, was assumed to occur in the absence of an external environmental cause and have a biological clinical picture. This is opposed to so-called reactive or neurotic depression, where it is assumed that the patient is to some degree understandably depressed, reacting to adverse psychosocial circumstances. However, most depression is a mixture of the two, and an understandable depression does not require any less treatment than a spontaneous depression or biological depression. Biological symptoms are still important to inquire about, as if present, they suggest a more severe depression. However, they are no longer viewed as providing information on etiology. These symptoms are, first, early morning awakening. Although patients may get off to sleep at their normal time, they wake at least 2 hours earlier than they would usually, and then find it impossible to get back to sleep again. Further disturbances of sleep in depression include difficulty falling asleep, this is initial insomnia, frequent awakening during the night and excessive sleeping, this is hypersomnia. Although all of these contribute to the diagnosis of depression, only early morning awakening is a biological symptom. Depression was in the morning. Diurnal variation of mood means that a patient's abnormal mood is more prominent at specific time of the day. A depressive mood consistently and specifically worse in the morning is an important biological symptom. Marked loss of appetite with weight loss. Although some depressed patients have an increased appetite and turn to comfort eating, only a dramatic reduction in appetite with weight loss, 5% of body weight in last month, is regarded as a biological symptom. Note that the reversed biological features of overeating and oversleeping are sometimes referred to as atypical depressive symptoms. Psychomotor retardation or agitation. The term psychomotor is used to describe a patient's motor activity as a consequence of their concurrent mental processes. Psychomotor changes in depression can include retardation, which is slow, monotonous speech, long pauses before answering questions, or muteness, laden body movements, and limited facial expression, this is blunted affect, or conversely, agitation, inability to sit still, fidgeting, pacing, or hand wringing, rubbing or scratching skin or clothes. Note that psychomotor changes must be severe enough to be observable by others, not just the subjective experience of the patient. Loss of libido. Sensitive questioning will often reveal a reduction in sex drive that may lead to guilt when the sufferer feels unable to satisfy their partner. Okay, that was about biological symptoms. Let's talk about cognitive symptoms. Cognition has two meanings in psychiatry. It refers broadly to brain processing functions like concentrating, learning, making decision, and also more specifically to the thoughts patients have about themselves and the world, which are conclusions arrived at by cognition. Like, I failed my math exam, therefore I will fail all exams. So, what are these cognitive symptoms? Starting from reduced concentration and memory. Depressed patients report difficulty in sustaining attention while doing previously manageable tasks. They often appear easily distracted and may complain of memory difficulties. They may feel indecisive. Okay. A communication tip here. Communication tip. Questions about concentration can include asking if they can follow their favorite TV program or read a novel. Okay. Another cognitive symptom is poor self-esteem. Self-esteem includes the interrelated concepts of personal efficacy and personal worth. Depressed patients may have thoughts that they are no longer competent to meet life's challenges and that they are no longer worthy of happiness and the healthy assertion of their needs. Another symptom is guilt. Depressed patients often have guilty preoccupations about minor past feelings. This guilt is often inappropriate and out of proportion to the original offense. Patients often have guilty thoughts about the very act of developing the depressed mood itself. Hopelessness. So, self-esteem, guilt, and hopelessness. Okay. Depressed patients can have bleak and pessimistic views of the future, believing that there is no way out of their current situation. Suicide or self-harm. Depressed patients frequently have thoughts of death and harming themselves. In severe cases, suicidal ideation may lead to an actual suicide attempt. At these times, patients may believe that they are faced with insurmountable difficulties or are trying to escape a relentlessly painful emotional state. We've talked about self-harm and suicidality in chapter 6. Okay, here we have a red flag. Risk needs to be assessed in every patient. So, risk needs to be assessed in every patient. During an assessment, the subject can be approached by saying that it's common for people who are depressed to feel that life is not worth living, and asking the patient if this has occurred to them. Suicidality can then be formally assessed as discussed in chapter 6. So, another kind of symptoms in depression is psychotic symptoms. We are talking about depressed patients or patients with depressed mood. Psychotic symptoms. In severe depressive episodes, patients may suffer from delusions, hallucinations, or a depressive stupor. These are termed psychotic symptoms. Delusions and hallucinations can be classified as mood congruent or mood incongruent, which describes whether the content of the psychotic symptoms is consistent with the patient's mood. Delusions and hallucinations in depression are generally mood congruent, and so many involve an irrational conviction of guilt or sin, or the belief that parts of the body are dead or wasting away. Hallucinations may take the form of uh, accus- accusatory or defamatory voices criticizing the patient in the second person. Let's get back to delusions. So, they may involve irrational conviction of guilt or sin, or the belief that parts of the body are dead or wasting away. Hallucinations may take the form of accusatory or defamatory voices criticizing the patient in the second person. This is auditory hallucination, or the smell of rotting flesh. This is type of olfactory hallucination. In severe episodes, psychomotor retardation may progress to the point of unresponsiveness, lack of voluntary movement. This is akinesis, and near or total mutism. Severe motor symptoms are probably more common in schizophrenia and bipolar affective disorder, but they can and do occur in unipolar depression. DSM-5, we call this catatonia, of course. So let's talk about the differential diagnosis. Careful history taking and examination should reveal whether the patient presenting with low mood is suffering from a primary mood disorder or whether their depression is secondary to a medical condition, psychoactive substance, or other psychiatric condition. Here we have a box that presents the differential diagnosis. An algorithm for the diagnosis of mood disorders is presented on. So, differential diagnosis of low mood. We have mood disorders like depressive episode, recurrent depressive disorder, dysthymia, bipolar affective disorder, and cyclothymia. Okay. Another differentials like schizoaffective disorder, secondary to general medical condition, or secondary to psychoactive substance use, including alcohol, or secondary to other psychiatric disorders like psychotic disorders, anxiety disorders, adjustment disorder including bereavement, eating disorders, personality disorders, neurodevelopmental disorders like mutism or ADHD, delirium or dementia. So let's tackle them all. Let's start with the first differential diagnosis here. Mood or affective disorders. Depressive episode. The ICD-10 has set out certain diagnostic guidelines for diagnosing a depressive episode. The minimum duration of the episode is 2 weeks. Again, the minimum duration of the episode is 2 weeks, and at least 2 of the 3 symptoms of depressed mood, loss of interest or pleasure, and increased fatigability should be present. A depressive episode can be graded mild, moderate, or severe, depending on the number and severity of symptoms and degree of functional impairment. A depressive episode occurring with hallucinations, delusions, or a depressive Sqour is always coded as severe with psychotic features. What about recurrent depressive disorder? Around 80% of patients who have an episode of depression will go on to have more episodes. The lifetime average is 5. Recurrent depressive disorder is diagnosed when a patient has another depressive episode after their first. Okay, let's get back to the criteria of ICD-10, the criteria of depressive episode in ICD-10. So, symptoms should be present for at least 2 weeks, at least 2 of the following core symptoms: depressed mood, loss of interest and enjoyment, and reduced energy or increased fatigability. You can notice here that we have 3 core symptoms in comparison with DSM-5. DSM-5, they just these include just the first 2, depressed mood and anhedonia. and some of the following: disturbed sleep, diminished appetite, psychomotor retardation or agitation, reduced concentration and agitation, reduced self-esteem and self-confidence, ideas of guilt, bleak and pessimistic view of the future, ideas or acts of self-harm or suicide. What about severity? Some difficulty in continuing with normal activities. This is mild. Moderate, considerable difficulty in continuing normal activities, but still able to function in some domains. Severe, unable to continue normal activities, and severe psychotic symptoms would be in cases with delusions or hallucinations. Okay. Another differential here is dysthymia. This is a chronically depressed mood lasting at least 2 years that usually has its onset in early adulthood and may remain throughout the patient's life with variable periods of wellness in between. Patient's mood is seldom severe enough to satisfy the formal criteria for a depressive episode and does not present with discrete episodes as in recurrent depressive disorder. Sometimes dysthymia has its onset in later adult life, often after a discrete depressive episode, and is associated with bereavement or some other serious stress. Note that patients may develop a depressive episode on a baseline mood of dysthymia, so-called double depression. Another differential is bipolar affective disorder or cyclothymia. Unipolar depression means that the patient's mood varies between depression and normal. When patients suffer from episodes of either depression or elated mood, often but not always punctuated by periods of normal mood, the disorder is termed bipolar, as the mood is considered to deviate from normal to either a depressed or elated or manic pole. When this instability of mood involves only mild elation and mild depression, it is termed cyclothymia. Bipolar illness and cyclothymia are discussed. We've discussed them previously in the previous chapter. Anyways. Okay, let's talk about another differential, which is schizoaffective disorder. A diagnosis of schizoaffective disorder can be made when patients present with both depression or mania, which is mood symptoms, and schizophrenic symptoms within the same episode of illness. It is important that these symptoms occur simultaneously, or at least within a few days of each other. Common pitfalls. Schizoaffective disorder is a difficult diagnosis to establish, as it is not uncommon to have psychotic symptoms in a severe episode of depressive episode with psychotic features. Likewise, depressive symptoms often occur in patients with schizophrenia. Schizoaffective disorder is discussed in more detail in chapter 9. Okay. Anxiety disorders. Many anxiety disorders are associated with a degree of low mood because of their unpleasant and pervasive effects. If the low mood is severe enough to meet criteria for depression, this should be diagnosed and treated fast. We'll talk about that in chapter 12. Adjustment disorder. Low mood may be one of several symptoms that appear when a patient has had to adapt to a significant change in life, like divorce, retirement, bereavement, and so on. And if the symptoms are not severe enough to be diagnosed as depression but are clearly related to a stressful life event, an adjustment disorder can be diagnosed. What about eating disorder? Eating disorders where nutrition is inadequate to maintain body weight and often associated with symptoms of starvation, such as low mood, low energy, and poor concentration. We'll talk about that in chapter 16. What about personality or neurodevelopmental disorders? Patients with disorders of personality or neurodevelopmental disorders often report features similar to depression, like low self-esteem, in mutism spectrum disorder, feelings of hopelessness, and thoughts of self-harm and suicide in emotionally unstable personality disorder. However, personality and neurodevelopmental disorders involve stable and enduring behavior patterns. unlike the more discrete episodes of a depressive disorder, which are characterized by a distinct, demarcated deterioration in psychosocial functioning. The last differential here is delirium or dementia. Low mood, apathy, and hypersomnia in an older adult can be a presentation of hypoactive delirium. Depression can cause marked cognitive impairment, but if it persists for more than a few months beyond the remission of low mood, dementia may be the underlying diagnosis, of course. So, the last thing to talk about here is depression secondary to general medical disorders or to psychoactive substances. Many general medical conditions are associated with an increased risk for depression. In some cases, this may be due to a direct depressant effect on the brain. However, any condition that causes prolonged suffering is a risk factor for depression. For example, like chronic pain. Okay. Both prescribed and illicit drugs can be etiologically responsible for symptoms of depression. Remember that alcohol is the psychoactive substance that is probably most associated with substance-induced depression. Okay, here we have this table that illustrate the general medical conditions associated with low mood. We have neurological conditions like multiple sclerosis, Parkinson's disease, Huntington's disease, spinal cord injury, stroke, especially left anterior infarct. This is for the left side of the frontal lobe that causes depression, head injury, cerebral tumors, and so on. Endocrine causes like Cushing's disease, Addison's disease, thyroid. It's just okay, that's good. Thyroid disorders, especially hypothyroidism, parathyroid disorders, and menstrual cycle related disorders. Infections like hepatitis, infectious mononucleosis, herpes simplex, brucellosis, typhoid, HIV, syphilis. Other medical causes like malignancies, especially pancreatic cancer, chronic pain states, systemic lupus erythematosus, rheumatoid arthritis, renal failure, porphyria, vitamin deficiencies like niacin, and ischemic heart disease. Another thing to know is some prescribed drugs that can cause low mood, like antihypertensives like beta blockers and methyldopa, steroids, corticosteroids, or oral contraceptives, neurological drugs like L-dopa and carbamazepine, analgesics like opiates and indomethacin, and others like antipsychotics and interferon. All these can cause depression. So, now let's talk about assessment, how we assess these patients who present with low mood. So, assessment. Let's start with history. The following questions might be helpful in eliciting the key symptoms of depression. About core symptoms, we ask: have you been cheerful or quite low in mood or spirits lately? Do you find that you no longer enjoy things the way you used to? Do you find yourself often feeling very tired or worn out? So this about biological symptoms, we ask: do you find your mood is worse in the morning or evenings? What time did you wake up before your mood became low? What time do you wake up now? Has anyone mentioned you seem slow up or restless? Has anyone mentioned you seem slowed up or restless? Sometimes when people are depressed, they have poor sex drive. Has this happened to you? About cognitive symptoms, we ask, how do you see things turning out in the future? Do you ever feel that life is not worth living? Are you able to concentrate on your favorite TV program? About psychotic symptoms, we ask, do you hear people say bad things about you when there is no one there? Do you smell anything unpleasant which is hard to explain? Do you feel your body is healthy? A collateral history from the patient's family, partner, carer, community psychiatric nurse, or general practitioner is often helpful. So, what about examination? A basic physical examination, including a thorough neurological and endocrine system examination, should be performed on all patients with depression. Investigations. Investigations are performed to exclude possible medical or substance-related cause of depression, establish baseline values before administering treatment that may alter the blood chemistry, like antidepressants that may cause hyponatremia, and lithium that may cause hypothyroidism. Another cause is to assess renal and liver functioning, which may affect the elimination of medication, and to screen for the physical consequences of neglect, such as malnutrition. So, to exclude possible causes, baseline, liver and renal function, and to screen for consequences. These investigations include full blood count. We check for anemia, low hemoglobin, infections, if there is any raised white count, and high mean cell volume, marker for high alcohol intake, MCV. With high MCV, this is high alcohol intake. Urea and electrolytes, we look for hyponatremia and renal function, liver function test, and gamma GGT, also a marker for high alcohol intake. Thyroid function test, we look for hyper or hypothyroidism, and hypercalcemia, and calcium for hypercalcemia. This is for routine checkup. CBC, urea and electrolytes, liver function, thyroid, and calcium. And if indicated, we may do C-reactive protein or ESR, erythrocyte sedimentation rate, if infection or inflammatory disease is suspected. Another test, which is vitamin B12 and folate, if deficiencies are suspected. Urine drug screen if drug use is suspected. Electrocardiogram should be done in patients with cardiac problems, as tricyclic antidepressants and lithium may prolong the QT interval and have the potential to cause lethal ventricular arrhythmias. Electroencephalogram if epileptic focus or other intracranial pathology is suspected. CT brain scan if evidence of neurological or cognitive deficit. So, that's it. Do you remember the case from the beginning of this chapter? If not, you can just get back to hear the case, because now we are going to discuss the case. So, Mrs. LM meets the criteria for a depressive episode, at least moderate in severity. She has had both core symptoms of depression for longer than 2 weeks, depressed mood, and loss of interest. She also has biological symptoms of fatigability, early morning awakening, and loss of libido. The GP has also elicited cognitive symptoms of feelings of incompetence, reduced self-esteem and guilt, and possible thoughts of self-harm. As this is a first episode, the diagnosis of recurrent depressive disorder is not appropriate. Dysthymia is not a suitable diagnosis, as the period of low mood is far too short. The severity of the present episode too great, and the deterioration in functioning too marked. There appear to be no instances of elevated mood or increased energy, excluding a diagnosis of bipolar affective disorder or cyclothymia. In order to grade the severity of the depression, it would be useful to inquire about all the biological, cognitive, and psychic components of depression, and to ask about functional impairment. Assessing Mrs. LM's ability to care for her young children is crucial and is likely to require a collateral history from her husband, with consideration of referral to social work if there are significant concerns. In all cases of suspected depression, it is imperative to inquire about thoughts and/or plans of suicide or self-harm. It's also important to rule out secondary causes of depression. These include general medical conditions, psychoactive substance use, and other psychiatric conditions. Mrs. LM admitted to using increased quantities of alcohol subsequent to the onset of her low mood. Advising her to abstain from alcohol is an important first step in managing her mood. Patients often use alcohol as a form of self-medication to alleviate feelings of dysphoria. However, alcohol can aggravate and in some cases even cause depressive symptoms. Mrs. LM's use of oral contraception long before the onset of her depressive symptoms suggests that it is unlikely that this prescribed drug is causing her depression. You can go to chapter 22 to read about the mood disorders and their management. We will talk about them in time. Chapter summary. A depressive episode is a sustained period of low mood, at least 2 weeks, associated with loss of interest or pleasure, fatigue, and functional impairment. A depressive episode can be associated with impaired cognition and/or psychotic symptoms. The key differential diagnoses for a depressive episode are a substance use disorder, anxiety disorder, or personality disorder. When assessing someone with depression, ask about the 4 domains of core symptoms, biological symptoms, cognitive symptoms, and psychotic symptoms. When assessing someone for depression, always ask about suicidal thoughts. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.